This topic is really close to home for me because I actually placed my mother onto home hospice in 2022. As her disease was progressing, we were discharged and now we're back on hospice. So I am bringing a wealth of knowledge, experience, and perspectives from navigating this system and can't wait to share with you all today.
Yeah, it's an
Um,
incredibly important experience of doing it, like being the caregiver. And so I think many of you who are watching are going to really resonate with what Jessica has experienced.
Yes. So we thought we would structure our session today kind of like a fishbowl conversation where all of you on this call and those of you listening to the recording will get a chance to engage with me, a full-time caregiver, someone who is in the experience, and with Adria, who is a clinician and an expert in supporting people living with dementia. And so throughout our conversation, if you have questions, please feel free to put them in the chat. We'll make sure to answer them if we can along the way. And then just know that we really only have 40 minutes, and so we won't be able to cover every little detail. But our hope is that we give you a chance to get insight in this experience and get an overview of the power and benefits of home hospice so that you feel confident and equipped as you're navigating your own journey. And Adria, I just read your talking points. We'll get it together.
That is okay. That is okay. We have a structure for this conversation. We wanted to make sure we hit on some things, but we are willing to go with the flow and really speak to the things you guys want to know. So we'll get to all the things as much as possible.
So before we do get into the conversation, we want to make sure we're on the same page around some terminology and we're
Mhm.
clear about what we are and are not talking about. And so for Adria, my question for you is when we say hospice care, what are we talking about in this context?
Yeah. So hospice is a specialized service, typically through a company or an agency, and it is for individuals who are at the end of life. And specifically, when we say that, the eligibility requirements are that someone has a life expectancy of 6 months or less.
Mm-hmm. Mm-hmm. And I know that many people actually confuse these services. So could you
Yeah.
explain like the high level differences between hospice care,
Mhm.
palliative care at home, and home health?
Yeah, yeah, good question. Definitely confusing. So I kind of want to take there's hospice care, which is I just said. So hospice is a specialized service. Palliative care is more of like an approach to care, right? It focuses on quality of life. It's a way of thinking. It's a way that we are going to navigate care. So if we were to see palliative care as like this umbrella term, or like if it's like this big circle, hospice would be underneath that umbrella. It would be inside. So hospice is a specific service under the umbrella of palliative care. Okay. So when we say palliative care, it's just that approach to care that we're going to focus on a person's quality of life rather than disease specific treatment, right? So for a lot of our lives, you have a splinter, you're going to focus on the treatment for it, right? To get it out. You have the common cold. You're going to take medication that's specific for that treatment for that condition. And we can go on from there, right? Cancer, where we're going to get a treatment for that condition. And so when we get, typically it's nearing the end of life, but it can be with any diagnosis, especially like dementia. We might want to shift our focus and say, instead of treating the disease, we're going to focus on just making someone comfortable. We're going to focus on maintaining quality of life over everything. So it's kind of broad, and the timing can be much more it's never too early for palliative care. You can focus on that at any point. Whereas hospice care is a very specific team that comes in. Someone, if you pursue hospice care, there's going to be probably a nurse or some kind of clinician that comes in that does an assessment and has to deem the person within 6 months of the end of their life. Um, And so then that kind of kicks something into gear. You have a team that comes in, which we'll talk about probably more. Um, and there's all these assessments that take place. So it's a much more structured situation. So we've got palliative care at the high level. We have hospice care, which is more specific. And when we say home health, that is not at all anything to do with end of life. Home health just means that is typically a service through a company or an agency, similar to hospice, but that team can focus on disease specific treatment. So you might have a speech therapist like myself, physical therapist, an occupational therapist that comes in, you have nurses that come in. This is a team that comes and helps someone who's been deemed to be either homebound or someone who is just it would be really challenging for them to get out into the community. And a lot of times, home health services are after a specific diagnosis of like a hip fracture or like something that's happened quickly, pneumonia, right? And someone has had kind of a quick progression. And the point of that is to get them better. Okay, so that's home health kind of separately, palliative care big, and hospice specific.
So helpful. I will say for those of you listening, my mother, we have used the services of home health with
Hmm.
occupational therapy, physical therapy, and skilled nursing. My mother was on palliative care at home, and then we transitioned into hospice. And so we've touched on all the pieces. So thank you for clarifying for us.
Yeah.
And then the last quick thing that we want to make sure is crystal clear is how does someone qualify for hospice care when they're living with a form of dementia?
Yeah, it's a little tricky because when we have someone who is diagnosed with a terminal cancer diagnosis, it's much more cut and dry what someone's life expectancy is because typically the doctors who are diagnosing that has a pretty expected path that that person is going to go down based on everything else. But individuals with dementia, especially with Alzheimer's disease, can live for 20 years with that diagnosis. And so, even though we might view it as a terminal diagnosis, right, it's something that they're going to have for the rest of their life, it doesn't necessarily mean that it's quick. So, when someone is eligible for hospice and it's from the dementia diagnosis, what we're looking for is someone to be in what we call the stage 7 of the global deterioration scale, or what's also known as 7C on the FAST scale. That is not really necessarily important for you to know, but what that means is that the person has progressed to the point where they're no longer ambulatory. So they're not up walking around on their own, they're not propelling a wheelchair on their own. Typically, they've gotten to the point where they're incontinent. This also means that they're largely bed bound. At this point, we also see communication being pretty minimal, and the person just needing total care. So they need someone else to help them, to change them, to turn them, to feed them. And so that's what we're looking for when someone is going to be eligible for hospice with a dementia diagnosis.
Thank you so much. There's so many things we could clarify on the front end, but those were definitely like the questions we often get. And so thank you for setting the tone for the things that we'll touch on today.
Yeah,
So
absolutely.
we're now going to move into our real time fishbowl conversation.
Mhm.
While you all are listening, if there are questions that pop up, use the chat or the Q&A feature so we can like gather them along the way. And then also just as you're listening, think about moments of your own connection and your own experience, potential overlap you might have. And hopefully, if the timing works out, you'll get a chance to share those reflections in the breakout space.
Absolutely. So, Jessica, I want to hear from you. So, now that we kind of have these terms that we've talked about, and you said yourself, you've done it all. So, you have experience here. Can you tell us about what diagnoses, what conditions or illnesses that your mother has experienced in the last few years, and which of those, or maybe a combination, factored into you deciding to pursue palliative care and eventually hospice care?
Yes. So, quick context, my mother was diagnosed at the age of 66. I was 26. My mom is currently 76. So, it's been a 10-year, very long journey. My mom has no other health conditions. Um, Alzheimer's disease is enough, but I say that because I like to make sure people know that there's no other comorbidities at play here. My mom truly is just living with Alzheimer's disease. There's no diabetes, no hypertension, high cholesterol, all of that. And so we got to the point of, what was it, 2022. Up until then, my mom was walking, moving about. Things were seemingly, fine for the stage that we were in. At the top of 2022, my mom's walking gait began to change. And I'm thinking that it's like something else. And I tried to look for every other thing, but I didn't realize that that was part of her like Alzheimer's disease progressing. My mother, by the end of February, top of March, was no longer able to hold herself up. So she would just like lean to the side or like lean backward. Like she had no core strength to hold herself up. And it became really difficult to help get her up to stand and walk on her own. So she was losing her mobility and eventually became no longer ambulatory by the time we hit the top of April. My mom, it seemingly happened suddenly, but there were changes over the last few months. But my mom also went from eating independently to now needing to be fed. And like I went from being able to give my mom a plate of food and an orange to now having to feed her with a spoon. And then by the time we reached the end of April, my mom was no longer able to get up, move, feed herself on her own. My mom was already fully incontinent. By that time, we had been in the hospital 3 different times for infections, UTIs mainly, but it's important to take note of the number of infections that were happening. And then, she started to fall because she was wobbly on her feet. And so the number of falls, the number of calls to the fire department just got me to the point where I realized that like I don't want to do the hospital anymore. I don't want to navigate potential for breaking bones, and just the stress of what it meant for very much caring for my mom, without any other like support or tools. And that is when I decided to ask her primary care physician about home hospice. So that was
Yeah.
spring 2022. That was like the lead up to that time.
Yeah. Yeah. And so what you described there, Jessica, was, when she started making some of these changes, especially when I remember when because I follow you on social media and we had been talking like through direct messages and stuff, when she made that shift from not being able to walk as well, and you could tell her gait was different, you were
Mhm.
kind of in that mindset of disease focused treatment that you had been for her whole progression up into there. It's like, okay, here's a condition, let's treat it. And
Mhm.
you tried the home health, you tried the physical therapy, and
Mhm.
realizing that this is something different, right? And so what I'm hearing from you is when you kind of made that shift of like, I don't want to go to the hospital anymore. I don't want to, put her through all of this. That shift, would you say that was kind of the palliative care shift for you, even before you made the hospice call?
Yeah, so I want to be crystal clear. It was our last hospital visit, and it was like the sounds of the beeping of the machines. Y'all know what the beeping sounds like, and the back and forth with the nurses and the doctors and the transport. And I was like, I will never put my mom through this again. And so that was like the clicking point for me. And
Mhm.
in that moment, I was like, I want to keep my mom at home, and I
Yeah.
don't want to deal with the stress and the hoopla anymore. At the time, that was me then saying, like, I want a more palliative care approach.
Yeah.
I didn't know to seek out palliative care as a
Right.
service, but I
Hmm.
knew that I wanted a palliative approach, and I asked about home hospice first.
Yeah.
Um, and because of the way in which my mom declined so fast in such a short amount of time, plus the weight loss, when they assessed her, she was a strong candidate at the time in 2022. And so
Yeah.
we went straight to hospice the first time.
Yeah.
I'm getting ahead of myself. I want to make sure I'm clear so I don't confuse people.
Yeah, no, but I think that's important. Sometimes we don't know to call it palliative care, but that's kind of that's the thing. It's kind of fluid. It's just an approach. It's like, hey, I want to do something different here. And I know also just personally that you also made a decision to like take her off medications too. So that was another kind of big step towards that.
Yeah, and that actually happened once we were on hospice. I think that people what I will say is hospice care and, like, working with a hospice agency honestly was the best thing I could have ever done for my
Mhm.
mom and for me as her caregiver, because it forced everyone just to slow down, and
Mhm.
it very much put me as the primary caregiver in the driver's seat, and, like, no one ever told me what I had to do for my mom or what they would suggest. It's like, whatever I wanted to do as her primary care like, person,
Yeah.
they listened, and that included me wanting to stop all these medication. My mom was losing so much weight. She was lethargic. She was quiet. Her appetite was changing. And I was like, can we just stop these things? And that was a personal choice.
Right.
But again, we were supported by them. And honestly, that was also a great decision on my part because my mom in many ways bounced back because she wasn't filled with so much stuff that was making her so tired. But that's a different
Mhm.
conversation. We won't go down that
Sure,
rabbit
sure.
hole.
Right. I want to acknowledge Esther in the comments. She said, in describing the progression, she said that seems like a fast decline. Is that typical of Alzheimer's? But I do want to remind people what Jessica said at the beginning. Her mom had been diagnosed with dementia for 10 years, right? Is that correct, Jessica? Kind of before these things happened, right?
Yes.
So everybody's situation is different and everybody will decline at a different rate. But you have 10 years and then some changes happen. And of course, she has had changes during those 10 years, but we're talking kind of about this end part. And Julie asked, is hospice or palliative care only if you're near death? Hospice is only for 6 months at life expectancy. So it is near death, but palliative care can be any time. So you said that we're kind of at the point in your story where you pursued hospice care. So when hospice came to assess your mom, can you tell us a little bit about what services and staff were available to you? Who came to your home? Who helped with your mom? And talk to us a little bit about how you accessed those resources.
I will say the very first visit and like the anxiety I felt before that first visit was very, very high. And so I just want to normalize if you all have not gone through that, or maybe you have, like the literal anxiety of someone else coming in and being proximate to our care story, and what it felt like taking over. All the feels. Okay. So I want to name that. So my first visit, I was so anxious. And I realized by the end of it that our hospice agency's job was to literally wrap their arms around us. And I say
Mhm.
us intentionally. It's not just my mom, the patient, but their job is to also wrap their arms around you, the caregiver.
Yeah.
And so in that came, you get the nurse, right? You get the person who, like, in your nurse, your RN is your person. You see them at least, depending on the severity of your disease, on a weekly basis. In addition to the nurse, I also had a CNA. The frequency of your CNA depends on your agency and, again, your state of your person. But my CNA came twice a week to help with bathing and changing and all the things, which was just like, any day you don't have to bathe your person is a win. Okay. So thank you. So CNA twice a week. We also had a social worker to help navigate just the local systems. If I needed help around Medicaid or even just like respite services, the social worker was really helpful with that. Our agency also had a chaplain should you wanted to click in and use them. Our agency also had a volunteer department. So literally I had two amazing volunteers come to my home and do like arts and crafts with my mom, play music, sit with her, read with her. Again, another body, another voice. My agency also had music therapy that happened every other week and massage therapy. I
Wow.
say those things last because that's not guaranteed.
Sure.
Okay. Every agency is a little bit different. And I would ask when you're searching and seeking out hospice agencies, what are the other supports that you have outside of what is guaranteed? You only are required to have the nurse. And then the social worker and CNA and chaplain are typical in like your basic hospice services. Everything else are like extracurricular fun things.
Yeah, yeah, absolutely. I think that's incredibly important to say is to ask because sometimes I know in my own family situation, hospice asked, how many times do you want an aide to come? And some caregivers might be used to saying, "Oh no, I've got it. I've got it. I don't need." I- Get those services that you are provided, right? I also want to clarify, I meant to say this at the top, but what we're describing is our experience in the United States. So if anyone is in any place else other than this, it might not necessarily be exactly the same situation, but I just wanted to name that. Jessica, I love how honest and open you are. You're authentic and you just like lay everything out there. So let me ask you a personal question. Can you tell us a little bit about the cost associated with hospice? And did it help relieve a financial burden? Did it cost more? Talk to us a little bit about the finances.
Yes. So hospice is covered by Medicare. Hospice falls under Medicare Part A, the hospital benefit, AKA the thing that all of you have or all your people might have if they're using Medicare. And so it's fully covered. So nothing comes out of my pocket as it relates to anything relating to home hospice. So when we needed a new hospital bed, hospice delivered it within 24 hours. I needed a new Hoyer lift, got it within 24 hours. Suction machine, and so like all of your equipment, wheelchair, high back wheelchair, covered through hospice. No sort of bill or cost associated. This is hospice, okay? There
Right.
are fees associated with that when you're not on hospice, but in hospice, free. Okay. The same thing goes with any sort of supplies. And so we got briefs, we got bed pads, creams, powders, gloves, wipes, like all the things you need that actually add up, are again covered under this benefit. And so, yeah, plainly, I think that, if the supplies are what you need and you truly use them, that cost goes away while you're on home hospice. And the equipment you have in this moment, again, doesn't get charged to you. So that's been great. I will say it also
Yeah.
relieved the burden of being able to have, like, when you're a caregiver, there's this sense of no one understands. I have no one to call. I guess I'll go to CVS at 11 o'clock to figure it out on my own. But like with home hospice, I can truly just text my nurse, or text someone that's on call and be like, I have this question or I need this thing. And they're like, we'll have it to you, in a reasonable, set of time. And so that's probably the best part, is that you have access to the materials, but also access to people. So you're not so alone in using said materials.
Right. Yeah. That's super helpful. Thank you for that insight.
Mhm. Yeah.
Um, all right, let's talk a little bit about this end of life kind of at where we are when we get hospice involved, what that looks like for someone with dementia, right?
Mhm,
Yeah.
mhm. I'm curious to hear from you what you see from a clinician perspective of, like, what are the things that you often see from patients when it's like, "Oh, maybe we should have this conversation about home
Yeah.
hospice."
Yeah. So we talked a little bit about what a person looks like as far as how much assistance they need, right? So they're incontinent, we've got nonverbal, bed bound, they're not ambulatory anymore. But also there are some common conditions and diseases that pop up when we're nearing the end to where hospice might need to be part of the conversation. And some of these, I know, Jessica, you have experienced. So the biggest one I want to talk about first is dysphagia, which is the term for difficulty swallowing. And so as a speech language pathologist, we diagnose, assess swallowing disorders, and so that is very common as even a cause of death for a lot of people with dementia, is that they do what's called aspirate. So they aspirate food or drink. Every time you and I eat, all of our food and drinks should be going right to our stomachs. But for someone who has difficulty swallowing and their muscles are changing, this happens not only because of weakness, but because of the neurological things that dementia does to the brain. It can actually cause food or drink to slip into the airway. And so it goes down into our lungs. And anything other than air that's in your lungs can cause an infection. And so that's called aspiration pneumonia. And so aspiration pneumonia is one of the most common things that people will experience at the end of life with dementia. We also might see things like bed sores, pressure ulcers, because someone is largely bed bound. That means that they're not moving on their own. They can't shift their own weight. And so what bed sores basically are just spots that get red. They can open up wounds from where they're just staying in one position, which is why it's so important to help someone move when they're at the end of life like this. We might just see recurrent fevers and infections like urinary tract infections, especially. This can lead to someone becoming septic, which is when an infection gets into someone's blood. We also will see frequent dehydration and malnutrition, which just might look like weight loss. And so those are kind of the big things that we see. Would you say that that's some of it's familiar to you, unfortunately, Jessica?
Yeah, I'm shaking my head. Like all of those things happened in their own way for
Mm,
us. I also think it was really important for me like not to jump quickly to be like, "Oh my gosh, she's not eating, therefore something's wrong." But it was like, "Actually, Jessica, she's no longer eating solids. I need to change how I'm preparing her food so that
mm,
that I'm not giving her the opportunity to choke and then, make it
yeah.
difficult to swallow." And so I do want to say like I noticed all those things happening, and I, as her caregiver, had to make adjustments to make sure that like I was covering all my bases before just assuming my mom couldn't eat anymore. I actually had to make the evolution so that I was making it easier for her to eat and remove some of the barriers that come from chewing a piece of chicken, right? Like,
Yeah.
so that's just important to delineate there. All of those things happen to us in their own way. The thing that I'll just say to caregivers on the call is that these things are part of the disease. They're not
Yes.
indicators of your quality of care, and
Yes.
they're not indicators of how well you're caring for your person. I was like, oh my gosh, why another UTI? Like, she's so clean. And like, when you understand how these
Mm,
infections form, you're like, okay, wait, that wasn't me. That's not, I'm not, failing my mom. And so I just want to name that because I think we often carry a sense of like guilt and frustration when new changes happen in our
yes.
loved ones with dementia.
I'm so glad you said that, because when you were describing, like, I had to adapt as a caregiver to help her swallow, I wanted to say, but even though there are things you can do to adapt, they still are going to happen.
Yeah.
Even from a clinician, we see it all the time. It's consistent across people at the end of life with dementia. So, yes, Jessica, I'm so glad you said that. It will happen. It's not a reflection of the quality of care that you're giving. Great
Hmm.
point.
Hmm. What do you see from your perspective to be the greatest challenge for families or decision makers around pursuing a more palliative approach and seeking an evaluation?
Yeah. I think that a lot of times caregivers just don't know what to ask for. And I think that there is, as a caregiver, you're the expert in the person you're caring for, right? But you are not the expert in the system that exists in the United States in medical care, right? And so a lot of times as caregivers, it's easy to feel like it is, you have to know if someone is, your person is eligible. You've got to figure it out yourself. And that's not true. For all of this, you need to be, you can ask your doctor to say, do you think they qualify for hospice? Can we get someone to come in? Because what's the worst that could happen? They say no, no, they don't qualify right now. Like, then you get a little bit more information and you move on. And so I think really just the expectation that you have to be an expert in how this whole process is going to pan out. Um, I feel like a lot of times caregivers feel that pressure. And the emotional side of things is a huge one too, is to feel like, I think a lot of times people feel like, and maybe I can just ask you this now, Jessica, when we make decisions, so my own grandmother has dementia and we are doing a palliative care approach with her. We have decreased a lot of her medications. Just yesterday, she refused a flu shot. And my mom called, like, what do we do? And I'm like, we're focusing on her comfort and her quality of life. And she, for whatever reason, this flu shot is causing her a lot of distress. And we need to keep it in mind. Our goal for her care, right, is to be comfortable and know that, yes, the flu poses a risk, but she doesn't want a flu shot. So we're not going to pursue a flu shot, right? So sometimes it's little things like that. But um, I know in my family, and probably for you, it's tempting to feel like pursuing palliative care or hospice feels like giving up. And
Mm,
so, can you talk a little bit about how you process that? Did you have those feelings, and what'd you do with them?
oh my gosh. So quick side note, when you said you don't have to know everything, my suggestion to anyone on this call is to stay in constant communication with your person's primary care, like primary care physician, because the more they know, the more story that they have, they can actually help you along the way, and it won't be such a jarring phone call out of the blue, because they actually have been following the progression of your person. Just a piece of advice.
Right.
But to your question, oh my gosh, when I called my mom's doctor and she was like, "Well, it sounds like your mom would be a strong candidate for hospice. Let's get her evaluated." When I tell you I cried, I went and I got in my car and drove to Crumble Cookie and got a whole box of cookies and cried. Because I was like, it's the I know I don't want to give up on my mom. Like that means she has 6 months or less to live. Like it was, all the things you hear, like so overwhelming. And those are valid feelings because society will have you I should say, we often only see hospice portrayed in the media as like, the very, very end. This person like is dying tomorrow. But when it comes to dementia and the space that my mom was in, I didn't realize that like, Jessica, breathe, calm down. You're now getting the supports to help make more sense of where you are and the transition that your mom is going through. And the reality is, and I can only speak from my own experience, Adria, and the rest of folks on this call, is that my mom, we put her on hospice the first time May 16th, 2022. And I deeply believe because, the stress was gone, we slowed down, she was the center of attention. My mom was discharged because she stabilized. And so she was discharged off of hospice after 11 months. That's not everyone's story, right? However, I think it illuminated for me that there is so much more to the story of hospice than just like you're giving up and the end is tomorrow for your person, especially living with dementia. Because as Barbara Karn says, like dementia doesn't play fair. And so your person can experience a huge decline, which my mom did. And then oftentimes they kind of stabilize out for a little bit. And then another
Mhm.
decline happens. And my mom stabilized that first time we were on hospice in 2022.
Yeah. And that was a question someone had is if someone lives for 6 months after they are on hospice, does that mean they're discharged or they're reassessed? They're reassessed for sure. But in hospice, there's something called a live discharge. I know that sounds so weird, but obviously hospice's goal is for there to be no live discharges. So for someone to be discharged while alive. And so I think the percentage last I looked is like over 80% of live discharges from hospice are people with dementia because it is so difficult to guess how long they have to live. And so you experience that. There's a reassessment period, but at a certain time, sometimes they discharge, and like you have experienced, you can kind of come back around later down the road and get access to those services again.
Can I just say that way people have some concrete, like a concrete example? So we were discharged in March 2020 three, yeah, three. And at the time my mom was stable, and I said, so what would it take for my mom to qualify for hospice again? And the nurse said like a major event or a major decline, a set of infections, significant weight loss. And
Okay.
so over a year passed, and so I put my mom back on hospice again. What was it, July this year, so 2024.
Okay.
And it is because my mom has continued to lose weight. She's lost 15 pounds from the last time that she was weighed in the hospital. My mom is also beginning to contract in her hands, in addition to all the other things. So she's still no longer ambulatory. She's still fully incontinent. She's still getting fed everything. So she's even more dependent on me. She's
Mhm.
majority nonverbal. And so those are the things that change for me to
Yeah.
give me the indicator that, like, okay, she would definitely qualify again. And she absolutely did, according to the nurse practitioner.
That's great. That's great information. It's that change in status. That's what they need to document, is that there has been a change. And so as a caregiver, if you can, during that time someone comes to assess, if you can verbalize very specifically what has changed, what you've seen, that can be very helpful in their documentation to make
Yes.
sure that they do qualify. And when hospice comes, that is not the time to brag on how great your person is doing. I do want to say that too, right? So you want to just be very realistic, right? It's not a reflection of your care. It is absolutely just, we need to just lay it all out there. Um, Rose asked if someone is going to do a discharge, do they switch back to palliative care? Let me give a couple of examples of what. So palliative care, like I said, this is not like an organized thing. Palliative care is just an approach to care. And so some decisions that my family has made for my grandmother who's on palliative care is that we're not going to push medications. There's certain ones that we try to give her every day, but if she doesn't want them, we're not going to push it. She's not going to the hospital anymore. And I know, Jessica, you mentioned that with your own mom, is that you're not going to pursue hospitalization. You're going to try to at home care for things as much as possible. You might make decisions like no more antibiotics, but it's all up to you and the person you're caring for. That is, palliative care is just like focusing on quality of life. It's not an organized, specialized kind of thing. So of course you can go back to that.
Can I just add, just
Yeah,
from my experience, Adria? So there's an account on Instagram called How to Train Your Doctor, and
love him.
he's really great. He's also a palliative care doctor. But um, when we were discharged, it feels like the rug being pulled from underneath you. Like it's the most jarring thing. Okay. And the thing he said is look in your area for local palliative care agencies. And I will say we had a palliative care agency in my local area. A palliative care, the service that we had essentially just meant that we had a nurse practitioner who came to our home on like a monthly basis. And that nurse practitioner essentially was someone who would check my mom's vitals, be someone who could just like get their eyes on my mom. She could write prescriptions if she needed them, communicate with my mom's PCP. That is palliative care at home. Is not available everywhere. But I do want to just name, yes, it's an approach, but it's also like there is a service of palliative
Right,
care that you can take advantage of that for us was a good in between hospice and now hospice again. And the
right.
biggest benefit, honestly, was having a medical professional come to the home and very much support us without me having to go anywhere else for testing, urinary draws, all that stuff. Like it all
Mm.
happened at home.
Great point. And Jane mentioned a hospice facility. I think that's one thing we haven't talked about. Hospice, that specialized service, can be provided to someone if they're in the hospital. It can be provided to someone at a nursing home, an assisted living. It can be at home. And sometimes there are specialized facilities that are just for hospice for someone to end their life there at the facility. So hospice can go wherever you are. And then some communities there are facilities there. So a couple questions I think is as we kind of wrap up, we're going to break into some rooms here in just a minute. But Jessica, I want you to talk to caregivers, give a little bit of perspective about if you think about the hospice professionals that have been in your home and part of your team, when you think of those who have been really helpful and that have been somewhat unhelpful, what are those characteristics and what did you as a caregiver do to kind of help manage those kinds of communications and making things as helpful as possible?
Yeah. I want to be really succinct. If you follow me on Instagram, I have plenty of rants about these things. However, the thing that I will say is the most helpful thing that any hospice professional entering your home, no matter what role they are, RN, CNA, social worker, is to truly be curious and to slow down and ask questions,
Mm,
right? Because just because you've seen so many people, no one person living with dementia is the same. And
right.
so the best folks are the ones who slow down to get to know me and anyone as a human, right? As the person who's caring for my mom, who gets to understand my mom's story and truly sees the bigger picture and takes the time beyond, collecting the vitals and moving forward. What I will say, folks, is that in the end of the day, leveraging hospice is a service, right? Therefore, I deeply believe it's your responsibility to like set expectations and name the things that you need. And so
Mhm.
I was really clear on the front end, right? Like these are the ways that I prefer to communicate. I prefer text message because of the disruption for my mom. This is the schedule that works based off of my work schedule. And like obviously it's not perfect, but what are you doing as a caregiver in the midst of so much unknown? You're creating some boundaries for them to work within. That way, it actually allows you to show up well and them to show up well for you. But I would say the best professionals are the ones who are curious and ask questions and remember the little things.
Mm,
That's the stuff that really makes a visit not feel like a visit, but someone just checking in on you.
I love
I will
that.
also say, folks, that when you're on hospice, if something doesn't feel right, or if you are not getting along with your nurse or whomever, you have every right to request a different nurse or a different
Mhm.
CNA. And like, again, it's a service. There's no harm, no foul there. Hmm.
Absolutely. And my last question for you, Jessica, is a little bit about family dynamics, which I know we could probably do an entire hour about. But can you give us a little bit of perspective about maybe what happens if there's someone in your life, someone in the family who doesn't think that a person is ready for hospice and kind of pushes back towards you pursuing that?
Mm. So I'm an only child and my mom's a single mom. So I had nobody pushing back on me. Okay. But it was truly just me. However, I got to see this real time with my uncle and my aunt. My aunt just passed this past weekend.
Mm,
And I'll never forget talking to my uncle a couple months ago and saying, have you all considered, and she had congestive heart failure. So it's not dementia, but still, I said, have you all considered leveraging home hospice? Because it sounds like there's nothing really else that can be done. And he was like, oh no, like she doesn't want that because it feels like we're giving up on her and da 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 da, da, like all of the things that we've talked about here. And I remember saying, Uncle so and so, this will ultimately be your decision with your wife. But I do want to say, like, if I'm gonna say her name, Aunt so and so wants to be home and wants to be comfortable and around the family and truly be treated with dignity and respect, right? And to no longer feel as if she's being poked and prodded, but to be in control of what happens, next for her. I think home hospice would be a great option for you all. And so after some back and forth and them realizing things, they eventually chose hospice. And I remember asking them, I was like, so how do you feel about this choice? And he was like, oh, this was great because now she's home. I'm no longer driving up and down to the hospital. The kids are here. And I remember on my aunt's deathbed, I said, are you glad to be home? And she said, yes. And so
uh,
there is something about honoring the human and
mm,
honoring the experience that you get when you truly leverage compassionate care for the person.
mm,
And so when I think about family members who might not be ready or who might have pushback, I try to put them back in the shoes of seeing their person as a human who deserves the utmost comfort, the utmost compassion and dignity and respect as they prepare to transition. Mhm.
absolutely. That's so good. And I think that hospice is a triggering word. I know even in my family, before my grandfather passed away, the doctor mentioned hospice at his bedside, and the whole family was like, I can't
Yeah.
believe he said that in front of them, you know? And and I get it because hospice does mean something. It does mean something, but if it triggers that fear and that resistance in yourself or in someone else, I encourage you to think about why that might be happening.
Mm.
And like we said, with hospice also comes a lot of practical help financially, like supplies and beds and lifts. And so and aides coming into the home to do the things that you're struggling to do. So So, big breath, right? We take a big breath here. We had a really great conversation, Jessica. Thank you for your authenticity and just being so open and honest about everything. There's so many more things I know we could have talked about during this time, but I think we hit as many questions as we could. So, before we completely close this session, we are going to break out into 2 rooms. I'm just going to throw you guys randomly into a room with either Jessica or I, and we're going to have about 10 minutes to talk. And this could be a good time too to make some connections with other people who are kind of in the same caregiving journey. But before we break, I encourage you, Tina mentioned it in the comments, following Hospice Nurse Julie. Jessica and I are big fans of hers. You're probably going to get our Instagram handles at the end of this, but I encourage you to follow Jessica. In real time, she is experiencing hospice and end of life with her mom, and she shares almost every single day, the good, the bad, and the ugly, don't you, right? Like, you get the real deal there. So, Jessica, if you don't mind typing your handle in the chat, someone's asking for it. And I thank you guys so much for being here. Like I said, it's Career Caregiving Collide. Yeah. So we're gonna break out into rooms right now, and we'll give you a prompt once we get in there. Okay, so we're just here for a few more seconds. I'm just going to tell everybody, I think we have everybody back. We are done with this session. Thank you so much for joining us. I know you still have questions. I encourage you to reach out to Jessica and myself on Instagram. There she is. And send us a message or peruse through our videos. You'll find a lot of answers, I think, there. We are going to jump back to the main room. You will see the next sessions popping up. And I was going to look and see real quick what they are. The next sessions
All in the
are,
Family, Managing Family Dynamics, and Good Grief, Finding Yourself After Caregiving.
thank you, yes. So we'll have a few minutes, and then around 10 after, so in about 7 minutes, that next session will start. So you have a few minutes, go to the bathroom, grab a drink of water, and we will see you in the next sessions. Jessica, thank you for your time.
Thank you, Adria. Love chatting with you.
Always. Thank you guys. We'll see you in the
Thank
next.
you. Bye.